Hi, so now let us start with this next very important, high yield topic, that is family planning methods and contraception. Of course, I know you must have read much in detail during your lectures from Dr. Sakshi ma'am or from OBS and Gynae faculty, but all said and done, you also need to know about family planning methods or contraception from community health perspective or community medicine point of view. So let's take it on and see what are the MCQs you need to know for your exam. Question number 1, what do you mean by eligible couple and what is a target couple? Beta, what do you mean by eligible couple? Eligible couple is a couple in which the female is in women of reproductive age group, in which the female is in WRA. MCQ, what is a WRA? We talked about this in demography as well, that what is a WRA? Please tell me what is WRA. It is 15 till 49 years of age. Different books will say 15 to 45. That is also correct. But from MCQ perspective, for your entrance exam, Government of India, we take 15 to 49 years of age. Eligible couple is a couple in which the female is in 15 to 49 years of age. That is eligible couple. Next is, what do you mean by target couple? Target couple is a couple who has completed family. That means they already have whatever number of desired children they wanted to have, who has completed the family or has at least one live child. So eligible couple is a different concept. Target couple is a couple who has completed the family with 2 children, 3 children, whatever number, or has at least one child. That is a target couple. MCQ over here is that contraception will be used for whom? What do you want to say? Contraception will be used for eligible couple or is it the target couple? What do you want to say? Please note that the eligible couple is for contraception. We want contraception to be for eligible couples. We want contraception for eligible couple. Now comes, what is the use of sterilization? Sterilization or permanent family planning methods, they will be used for target couple. Sterilization or the permanent methods, our main focus is for the target couple. I think it's pretty simple to understand. Next is question number 2. What is a planned family? Please note that planned family is a family in which the female has first child after 20 years of age. After 20 years of age, the female becomes the mother for the first time. Planned family is also a family in which the first child is after 2 years of marriage. A planned family is also a family in which the gap between children, first and second child is more than 3 years or at least 3 years. And lastly, planned family is also a family which has no unwanted pregnancies. So all these are definitions of planned family. Question number 2 for you. So what is a planned family? In which the female has attained the age of 20 years before becoming the mother for the first time. The planned family is also a family in which the gap between the children is more than 3 years. The planned family is also a family in which the first child is after 2 years of marriage. And planned family is also a family which does not have any unwanted pregnancies, and therefore the family is practicing contraception. Question number 3. What do you mean by the failure rate of the contraception? See, contraception is to prevent unwanted pregnancies. So, of course, contraceptive methods can have some failure rates. The failure rate is assessed in 2 methods. We can assess the failure rate in terms of life table analysis. We can assess in method of life table analysis, or we can also see the failure rate of the contraception in terms of the Pearls index. What do you want to say? Which of the following is the best method for assessment of failure rate of the contraception? Please note it is life table. I know your heart would be saying Pearls index, but please note that life table analysis is one of the best methods to find out the failure rate of the contraception, because it is pretty simple. How do you calculate the life index? You just take the female, you follow the female for all her reproductive years. You see that the female has been using contraception for how much time and when did the unwanted pregnancies occur. Of course, it is the ideal way. It is the best way. But most of the times we cannot calculate the life table analysis. It is the ideal or the best, but usually, most commonly, what we do is Pearls index. MCQs on Pearls index. What do you mean by Pearls index? What do you mean by Pearls index? Pearls index is given by the formula total number of accidental pregnancies. Total number of accidental pregnancies divided by the women years of exposure multiplied by 100. Please note the multiplicative factor is 100. So that is the formula for Pearls index. It is the total number of accidental pregnancies divided by the women years of exposure. How do you define the women years of exposure? It is divided by the total women into the years of use of contraception. So that's how we calculate the women years of exposure. Now, if the examiner comes up and says that, can you tell me the Pearls index because I calculated the total women multiplied by not the years but the months. So what is the formula? So in case the examiner says women months of exposure, now your multiplicative factor will be into 12. That is 1200. So that will be your Pearls index. Please note that Pearls index is the indicator. Pearls index is the most important indicator for family planning or contraceptive methods. Please note that usually, I'm not saying as a landmark, but usually it is said that the Pearls index for condoms or the barrier methods would range somewhere between 2 to maybe 20%. For intrauterine devices, they usually range around 0.7 to 1.5 per 100 women years, not percent, per 100 women years, HWY. HWY stands for 100 women years. The Pearls index for intrauterine devices is 0.7 to 1.5 per 100 women years. And for OC pills, it is usually less than 0.1 per 100 women years. Okay, so please note that Pearls index for most of these is ranging between around 1%, you can say, 1 per 100 women years, except for condoms or the barrier methods, which has typically higher Pearls index. Coming to our main definition, like what is Pearls index? Pearls index will tell you about what? Pearls index will tell you about the accidental pregnancies. It is measured in terms of what? It is measured in terms of per 100 women years. It is measured in terms of the per 100 women years. So these were your simple basic 3 MCQs you need to remember. Coming to the main topic now, what do you mean by contraception? Contraception is to stop the unwanted pregnancies. Contraception can broadly be classified into 2 types. We can have a temporary methods of contraception, or we could have the permanent methods of contraception. What are the temporary methods of contraception? The temporary methods of contraception could be simple, very simple, natural methods. We can have barrier methods. We can also have the intrauterine devices. We can also have the oral contraceptive pills. We can also talk about in temporary methods about the implants or the injectables, or some other methods of contraception, some other different methods. We will talk about these temporary methods of contraception. Coming over to the permanent methods of contraception, permanent are like usually irreversible automatically. So once done the procedure, they will stay with the body for a longer time. So that is what is a permanent methods of contraception. Example for this is pretty simple. You can have tubectomy, or you can have vasectomy, or you can have some other methods. So these are the three things you need to understand in permanent methods of contraception. So now let's take on the natural methods of contraception. The natural methods, first one is pretty simple. It is abstinence, that is avoidance of the sexual intercourse, or coitus interruptus, or the withdrawal method. Withdrawal method, where the male will take out the penis just before ejaculation. That is simple, no MCQ on this. Second, we can also have some other methods of contraception like the calendar method or the rhythm method. So what do you mean by the calendar or the rhythm method? See, if you have studied the menstrual cycle, normal menstrual cycle, there are some fertile phase. So understanding that fertile phase, during the fertile phase of menstrual cycle, the female will be fertile. That means that is a safe period of for intercourse, or unsafe, that is taken as the unsafe period. That is taken as the unsafe period. So simple, that is rhythm method or calendar method. One MCQ which can come on the rhythm method or calendar method is called as the Tirumala method. Tirumala method, or the cycle of beads. Cycle of beads. What is this cycle of beads? Pretty simple to understand. As you can see on the screen, there are different beads are there, right? So different beads, you can see different beads. They have been attached together. The first bead is a red color bead, as you can see here. So different bead sizes or different things can be there. Different colors you can have: red, brown and green, red, brown and white. So different cycle of beads are available. But usually one red color bead has to be there. So what is this red color bead? Red color bead is for the start of the menstruation. Start of menses is what will be the first bead. So when a female will start her periods on the first day of her menstrual cycle, she will put a rubber band kind of thing. There is a rubber band which she puts on the first bead. Now, as her menstrual cycle every day will grow, like every day passes on, so the beads will pass on. The rings is the rubber band is passed on to the different rings. So like on day 1, day 2, day 3, day 4, day 5 and so on. So this method is basically for females who are not able to read and write. They don't know what is 1, what is 2, what is 3. They don't know that. So many areas, in rural areas and tribal areas, the female won't be knowing what is a calendar. So what we give to them is this beads. So the female is going to put the rubber band every day, every day, every day. And when the rubber band will cross the brown color beads or the dark red or the maroon color beads and enter into the next phase, that is the white color beads, this phase will be what? What do you think? This phase will be safe or unsafe? Common sense, this will be the unsafe period for coitus. So technically this is what is cycle of beads. It is dependent on the calendar method or the rhythm method. Please note that the cycle of beads method, this method has a disadvantage. It cannot be used for females with irregular cycles, with irregular bleedings, and it cannot be used in females with very short or very long menstrual cycle, menses, very short menstrual cycle or very long. So technically this bead method, as you can see, can be used only between 26 to 31 days. If the cycle is between 26 to 31 days, the cycle of beads can be used. So if it is ranging more than 31 days, like 32 days or more, then this beads cannot be used because the beads will fall short. If it is less than 26 days, again, this method cannot be used because the rubber band will give you erroneous results, right? Common sense. So what are the cycle method or the calendar method or the rhythm method. Moving over to the next point, that what is lactational amenorrhea. See, in a pretty simple language, when a female starts lactating after delivery, the lactation period is generally minimum for 6 months. So when her lactation is going on at that time, there is usually no menstrual cycle. The menses do not start. So during lactation, the female has a physiological action. There is a physiological mechanism of amenorrhea. So MCQ over here is that, is lactational amenorrhea a type of primary method of contraception? Answer is no. Lactational amenorrhea is simple, a physiological response by the body. So in very simple words, what is the contraceptive contraceptive of choice. What should be the contraceptive of choice during lactation? So that is what the question will be. I'll write it as COC. In future also, I'll be writing it as COC. So the contraception of choice for lactation amenorrhea, as per the Government of India guidelines, it is progesterone only pill. Please do not mark that lactational amenorrhea is enough for the female. Please note that lactational amenorrhea is a physiological response by the female. It is having a very high failure rate and it is unpredictable to talk about the ovulation. So at that point, what is the contraception of choice? It is always, always, always important to advise the female with the contraception of choice, that is the POP. And now moving forward, the next method of contraception could be, we can talk about the basal body temperature method, or we can have the cervical mucus thinning method. Please mind it, it is a cervical mucus thinning method. Okay, let's talk on these. What do you mean by the basal body temperature? See, in a male or a female, usually our body temperature is pretty standard. In a female, around ovulation or just before ovulation, the basal body temperature tends to increase. How much it increases? 0.5 to 0.8 degrees Celsius. There is a rise in the body temperature. 0.5 to 0.8 degrees Celsius rise in the body temperature. So now there is a point for you to understand. When does it happen? It happens just before ovulation. It happens just on the day of ovulation or just before a few hours from ovulation. So in a basal body temperature, you can record the temperature of the female, and when the temperature is highest or it peaks, that usually corresponds to the ovulation on that day. So do you think at that day it will be fertile or a safe period or unsafe period? Obviously, common sense, it will be unsafe period. The female is fertile because she's just now ovulated. But the point for you to understand is that basal body temperature, is it a good method of contraception? Or do you think that basal body temperature is a very good method to ascertain the fertility or the ideal time to give fertility to the female? What is better? Please note that basal body temperature is not a very good method of contraception. It is a good method to find out the fertility. It tells you about more about the fertility in a female rather than the contraception. Okay. Next, what do you mean by the cervical mucus thinning method? See, when the female, let us say this is the timeline, and let us say on particular one day, the female starts menses. So her bleeding is there for next 3-4 days, 5 days, whatever number. And then there is usually the onset of a dry phase. Then there is a dry phase, and then the cervical mucus will start increasing, and it reaches a particular peak and then it comes down. When is the peak? It is just before ovulation. Just on the day of ovulation or just few days before, it is going to peak. This peak is with the LH surge. So I think much more in detail you must have learned during your gynae section, but I want to just convey over here that it is the cervical mucus thinning. The cervical mucus becomes very thin and it becomes copious. When will it become thin or copious? It will become thin and copious when just around the ovulation. So just around ovulation, if the cervical is thin and copious, so do you think at that time the female should be having coitus? If she was wanting contraception, of course, that becomes the unsafe period, right? So again, cervical mucus thinning method. I'll write it down, beta. That cervical mucus thinning method, it is again a method of what, to find out the fertility or to find the contraception. It is more for fertility, because when is the most fertile phase? When the cervical mucus is most thin and copious, very thin and copious. Okay, I'm not saying that it is not a method of contraception. I'll come back to this slide. You can see that as the cervical mucus starts thinning up, the female is advised not to have intercourse. So it is a good method of contraception, but it is one of the best methods or more specific method for what? For finding the fertility. Of course, cervical mucus thinning also tells about contraception. It's not like basal body temperature, which is like all or none phenomena. It is a method for contraception and fertility both. Okay, so coming to both of these answers now, if you just see that the cervical mucus thinning and the basal body, usually the female can use both these methods together. If a female is using both these methods together, That means if a female is using both the methods, that is the basal body temperature and the cervical mucus thinning method, that method is called as a symptothermal method. Symptothermal method, because you're talking of the symptomatology of the menstrual phases and along with the thermal phases, that is the basal body temperature. Or usually it is said that as far as your MCQs are concerned, it is said that combining any two natural method, out of which one should be basal body temperature. So combining any two natural method, out of which one should be basal body temperature, with any other method of natural method of contraception is called as symptothermal. So you can write down what is symptothermal method. Symptothermal method. Symptothermal method is combining the basal body temperature method along with any other natural method of contraception. Combining the basal body temperature method along with any other natural method of contraception, that is what is a symptothermal method of contraception. So let's move ahead. One more point for you, that what is this cervical mucus thinning method known as? Please note that it was just this method was invented, it was more researched by Dr. Billing from Australia, and that's the reason cervical mucus thinning method is also known as Billings method. It is also called as the Billings method. So that was regarding the natural methods of contraception. Now moving over our story to the barrier methods of contraception. Beta, the barrier methods of contraception could broadly be like, we need to talk about the condoms, of course, slightly more in detail. We also need to talk about what do you mean by the Dutch cap or the diaphragm, about the cervical caps, maybe a few questions about the sponge also, right? So what MCQs on condoms? Condoms can be of two types. We can have male condoms or we can have a female condom. The female condom or male condom. The male condom has only, I think everybody must be seeing a male condom. Male condom has only one ring. Whereas a female condom, it has two rings. It has two rings. One is called as internal ring. Another one is called as the external ring. External ring. The external ring is what is opened. It is open. And the internal ring, that is what is closed. So a female just has to insert the internal ring inside, and the internal ring will rest or cover the cervix in the female. So it is closed. So of course the penis is going to enter here and the sperms are not going to go anywhere. It is a method of contraception. That's the general understanding about the female condom. And now moving forward, in the male and the female condom, if we just see that the male condom is made up of a material called as latex. That's a kind of a rubber. And female condoms could be of various types. You can have the FC1, the FC2 or the FC3. The FC1 is made up of polyurethane, and that is not available in India anymore. It is not used, in fact, in many parts of the world. The FC2 condoms, these are available, MCQ over here, these are available under the NACO program. What is NACO program? National AIDS Control Organization. And this FC2 condom is made up of latex again. So latex is more robust and it's more stronger. So we can have FC3s, which are also made up of other synthetic material, but the condom which is available in India under the NACO program is FC2 condom. The male latex condoms, these are available under a brand name of Nirod, and these are Nirod condoms, and these are available at all the Government of India health machinery, at the sub-centers, PHCs. They are given by the National Family Planning Program. NFPP stands for National Family Planning Program. And NACO stands for National AIDS Control Program. Please mind it that I have said that the male condom is available under the Family Planning Program, whereas the female condom is available by the NACO program. The male condom is Nirodh condom. It is manufactured by the HLL, which is located in Trivandrum, Kerala. Hindustan Latex Limited, Trivandrum, Kerala. And it is taken care of around 17 to 20% of the market share. And please note, most common type of condom available in India is the Nirodh condom. So that was a couple of MCQs about the male and the female condoms. One thing more over here I would like you to remember is regarding the RTI STI. What is RTI STI? RTI STI stands for the reproductive tract infections and sexually transmitted infections. So basically, when we are talking about the RTI STI, which one is more like better, or which one is more protective in preventing the RTI STI? Please note that as far as the RTI STI is concerned, the male condom is equal to the female condom in prevention of RTI STI. But still, if you get the single best response, you know sometimes how the MCQ makers are. So in case you get stuck up in that idea that which is a better barrier method for preventing RTI STI, male condom is slightly better than the female condoms. Talking next is about the cervical caps, the cervical diaphragms, and the vaginal sponge. Please note that the vaginal sponge, cervical caps, and cervical diaphragms, they are not regulated and they are not recommended by the National Family Planning Program, by the Ministry of Health and Family Welfare. However, they are available in the private supply in India. So what is a cervical cap? It is simple cap which covers the cervix. It's a simple cap. It is a U-shaped cap which covers the cervix. So of course, if it covers the cervix, the sperm cannot enter the cervix. That's all. End of story. What is cervical diaphragm? Usually diaphragm will also cover the cervix. It is more flattened. And this cervical diaphragm we also call it as a Dutch cap. The vaginal sponge, that is available by the name of Today. In India, it was available. Nowadays, Today also is not recommended. The Today vaginal sponge, it was impregnated with the spermicidal jelly. What is the name of that spermicidal jelly? That is nonoxynol number 9. So it is impregnated with the spermicidal jelly, that is nonoxynol 9, and currently in Government of India, we are not recommended either the cervical caps or the sponge or the diaphragm. The problem with these is that the cervical cap or the diaphragm or the sponge, they should be inserted common sense before the act of the coitus, right? Before the sexual intercourse, they have to be inserted. And the problem with caps, diaphragm, and the Today sponge is that they should be left inside the female genital area in the cervix, near the cervix or in the vagina for roughly 6 to 8 hours. Now, in case the female forgets to take it out, they should not be kept for more than 24 hours. Because after 24 hours, there is a very high risk of toxic shock syndrome. So please note that these are not recommended by the Government of India. In case the female is using it, these devices have to be inserted before the coitus and they should be left inside the vagina for 6 to 8 hours. And because they are left inside the vagina, there is a hypothetical chance that the female may land up into a rare adverse effect, that is the toxic shock syndrome. So now we can just have a look at some of the image-based questions which can be asked in your exam. What you see on the screen right now, this is what is a Today sponge. This is what is a vaginal sponge. And you can see it is inserted inside the vagina and the female needs to place it just near the cervix so that it can cover the cervix, and there is an nonoxynol 9 which will prevent the entry of the sperms into it. What you see on the screen right now, this is what is a cervical cap. It covers the cervix completely. It is a U-shaped structure. A more close-up diagram you can see over here is the cervical cap. It is a U-shaped structure which is going to cover the cervix totally. And then you have a cervical diaphragms, which are like more of flattened diaphragms. You can see the diaphragms, and these are also called as the Dutch caps. Next is if you just have a look at this female condom, you can see that the female condom has two rings. One is an internal ring and one is an external ring. The external ring is opened and the internal ring is fused. It is closed and it covers the cervix. And please note that the female condoms are available under the NACO program. This what you see on the screen is the Nirod condom. I would like you to be appreciating this fact. I would like to bring to your notice that I'm not saying there were initially we launched the condoms under the brand name of Asha. Asha is what? It's a double ASHA. Asha is just a brand name which our government of India, any type of contraception will be launched under the brand name of Asha. So now the problem starting was that the condoms were named as Asha condoms and they somehow did not have a positive impact on the population, because then the Asha's image in terms of the responsibility and accountability was compromised. So the Ashas retaliated to their name being used over the condoms, and therefore the government of India accepted this proposal, and today this Asha word has been dropped from the condoms. Asha, however, the word remains with the female contraceptives, not with the male contraceptive. You should be appraised of this fact. So these, what you see is the deluxe Nirod condoms that we have in India. And these are the packets of Nirod condoms, which I think many of you must have seen. Next in line is what are the intrauterine devices, that is the IUCD. What is the full form of IUCD? IUCD stands for intrauterine contraceptive device. Please note it's not an intrauterine copper device, it's an intrauterine contraceptive device. First MCQ, what are the types? See, if you just look at the history of intrauterine device, it has a very rich history and a very fascinating history. Long time in the medieval times, Egyptian times, people used to cross deserts, right? So they used to cross deserts on camels. And while their journey used to be a few hundred miles, they could not afford that the camels would reproduce on the way or have babies on the way, because in that case, their journey would be halted, right, of the whole population. So they used to ensure that before they start the journey, the camels should be made infertile so that they are not able to reproduce during the next travel period of few months or years. So for that reason, they used to make the camels infertile. How? By putting something, cotton wool or sheep wool or metals into the uterus of the camel, which makes the camel infertile. So it has a very fascinating kind of history. And there was this person called as Richard Richter, who started using for the first time some foreign substances into the uterus for humans. So that is usually called as he's the pioneer of intrauterine devices along with Grafenberg. They both are known to have done a lot of work on intrauterine devices. So let's have a word about MCQs, like what are the things you need to know, what are the types of intrauterine contraceptive device. These contraceptive devices, these are known as generations. So we can have the first generation, the second generation, or the third generation of the intrauterine contraceptive devices. First MCQ, what is the first generation? The first generation is an inert IUD. The second generation, these are copper-containing IUDs. The third generation are what are the hormonal IUDs. So you can have the inert IUDs, copper-containing IUDs, or the hormonal IUDs. Next MCQ, what are the examples of these? The inert IUDs example could be Lippes loop, or we can also have Grafenberg ring. Grafenberg ring was the first official IUD which was used in the intrauterine devices, and Grafenberg is also known as the father of intrauterine devices. The copper-containing devices, examples for these could be the copper T200, copper T220, copper T380. We can also have the multi-load devices. The multi-load devices could be 250 and copper T375. These are the copper-containing IUDs. So I would like to bring to your highlight over here that copper T380 and copper T375. These are the two intrauterine devices which are used by the government of India. So these two intrauterine devices are available under the government of India scheme. Next is what are the hormonal IUDs? hormonal IUDs could be two. We can either talk of Mirena or we can have a Progestasert. Please note Progestasert. Please note that Progestasert is only left for your MCQ purpose. It is no more recommended by the Government of India, and it is no more advised by many of the health practitioners also in the country, because of probably side effects. The most commonly hormonal which is used is the Mirena. Next is, let us have a few MCQs on these, like what are the questions which can come. First is, you should know what is the lifespan of these intrauterine devices. Please note that as far as the Copper T 380 is concerned, it is applicable for 10 years. As far as the Copper T 375 or the multi-load device is concerned, it is applicable for 5 years. It is also called as a short-term intrauterine contraceptive device. It is also called as short-term intrauterine contraceptive device. Mirena can be used for 5 to 7 years. If you get the single best answer, the Government of India recommends Mirena to be used for 5 years. Next is, if you can remember about the Progestasert as well, it is applicable for 1 year. So that's the lifespan of these intrauterine devices. Very frequently you get question. So Copper T 380, please note 10 years. Copper T 375, 5 years. Progestasert is for 1 year. Mirena is for 5 years. You can just remember it on a very easy platform. Coming to the next MCQ. What are the differences between Mirena and Progestasert? A little bit more in detail about Mirena and Progestasert. Both are types of the hormonal contraceptives. The Mirena, bache, please remember that Mirena contains what hormone? It's a hormonal, right? It contains which hormone? It contains a synthetic progesterone, that is levonorgestrel. Whereas Progestasert, it contains a natural progestin. Mirena is loaded with the levonorgestrel in tune of 52 milligrams, whereas Progestasert has only 38 milligrams. This Mirena is secreted every day. It secretes the levonorgestrel every day. It secretes at the rate of 20 micrograms per day. The secretion of levonorgestrel is at the rate of 20 micrograms a day, whereas the Progestasert, it secretes at the rate of 65 micrograms per day. Progestasert, we already have done, is applicable for 1 year. Mirena is applicable for 5 to 7 years. Mirena is also called as LNG20. Why LNG20? Because it contains levonorgestrel and it secretes at the rate of 20 micrograms a day. So which one is more preferred? Please note that in Government of India machinery, we have Mirena, which is more preferred. So now coming over to a few more questions about the Copper T 380 and Copper T 375. So both are available in the Government of India machinery. If you just have a look at all the Copper T devices now with us that are available with us, we have a Copper T 380. This is what is a Copper T 380. So what do you mean by the Copper T 380? If you just have a look at, I can show you the Copper T 380A. If you just look at this is Copper T 380A. Why do we call it as a copper and why is it a T? Because it is a T-shaped structure or a T-shaped device. Why do we call it as copper? Because it contains copper. Why is it 380? Why? Because 380 is what is the surface area of copper in terms of millimeter square. So this Copper T device, it contains how much copper? It contains 380 millimeter square of the copper. Why do we have this A? A means that the copper is there on the arms also. A stands for the arms. Copper is there on the arms also. So that is what is a Copper T 380. If you look at the Copper T 375, Copper T 375, can you see? It's an inverted U shape. It is inverted U-shaped device, whereas the Copper T 380, it is a T-shaped device. Copper T 380 has 380 millimeter square of the copper, whereas a Copper T 375, it has only 375 millimeter square of the copper. Please note, in a Copper T 380A, there is arms also have copper. Arms also will have copper, whereas there is no copper on the arms. If you see this Copper T 375, it has these kind of spurs. It has these kind of spurs which help in the myometrial attachment. They help in attaching to the myometrium more sturdily, right? So that is what is the function. If you just see that the IUD is there inside the myometrium, inside the uterus, and the IUD is attaching to the uterus. So now coming back to my story over here. If you just take a pen and you take out the refill, let us take out the refill of this pen and let us say that this is the empty thing which is left with us. So this will be called as inserter, and the refill, let us call this as the plunger. So what happens in a IUD Copper T 380 is we will take the Copper T 380, this Copper T we will take, and we will fold the arms. The arms are folded and they are inserted within this inserter. So now this inserter is there. I can just show you that. Let us say that this Copper T is there within the inserter now, like this. Are you getting it? So you have put this Copper T inside the inserter and now there is a plunger. So what you do is when we are inserting inside the uterus, there is a cervical guard. Okay. So once you insert it inside the uterus, the cervical guard is there, which will not let the inserter go more into the uterus. So it stops there. Now what you do is, listen carefully. Now what you do is you take the inserter and you take the plunger, you hold the plunger and you pull back the inserter. You hold the plunger and you pull back the inserter. If you hold the plunger and you pull back the inserter, what will happen to the intrauterine device? Can you imagine? The plunger is here and the inserter goes down. So the intrauterine device will open. So how do you insert a intrauterine device? Is it inserted using a push technique or a pull technique? It is always inserted using a withdrawal technique. Withdrawal. You always withdraw the inserter. Okay. Now there is a problem with the Copper T 375. In Copper T 375, these are having spurs. You cannot, these are flexible arms. You cannot put them inside the inserter. So these arms will stay outside the inserter. It will look something like this, that this is the inserter. The Copper T is inside and the arms are outside like this. That's how it will look. Can you get me? So now in this Copper T 375, there is no point, there is no use of the inserter, of the plunger. So we just take the inserter, the Copper T is loaded on the inserter and it is just softly put inside and the IUD will automatically attach to the myometrium. So that's the beauty of Copper T 375. Please note MCQ which can be asked to you, that there is no plunger rod. Can you see that there is a plunger rod in Copper T 380? There is a plunger rod in a Copper T 380, whereas there is no plunger rod in the Copper T 375. Another difference that you would like to point over here is that in the Copper T 380, the thread is always there, as you had seen in this intrauterine device. You can always see that there is a IUD. There is a IUD string which is there. Why is there a string? It helps in the female to manually palpate and find out whether the IUD is in place or not in place. So what's the difference between a Copper T 380 and a 375 is that in Copper T 380, there is a polyethylene thread. There is a polyethylene thread. Whereas in a Copper T 375, it is a monofilament nylon thread. There is a monofilament nylon thread. Please note these are important differences. So in Copper T 380 it's a polyethylene thread, whereas in Copper T 375 there is a nylon thread. The Copper T 375, this I know may not be an MCQ as such, that the nylon thread that we are getting in the Government of India, it is a bluish green. It is a bluish green color thread in the Copper T 375, whereas in the Copper T 380, it is a white color thread. In Copper T 380, it is a white color thread. And the white color thread is made up of polyethylene. And please note that in Copper T 380, we have inserters, we have plungers. In Copper T 375, only inserter, no plunger. So these are some of the very basic MCQs which you can get. I hope I have already done this. Copper T 380 is applicable for 10 years. Copper T 375 applicable for 5 years. So these are some of the very basic MCQs which you need to remember for your exam regarding the differences between a copper T380 and copper T375. So this is what is a copper T380, and this you can see is the Progesta cert. Please note that the Progesta cert, it will be a tubular T-shaped structure. Whereas if you talk about the Mirena, it's a simple T-shaped structure with the curved ends. It will have curved ends. Mirena is with curved ends. Next MCQ is, what is the mechanism of action of intrauterine device? If you talk about the mechanism of action, I'm asking you, what do you want to write? Is it the inhibition of ovulation? Is it the inhibition of fertilization? Is it the inhibition of implantation? What's your best answer? What do you want to write? Please note that the primary mechanism of action of intrauterine device is inhibition of fertilization. Please note that it does both fertilization and implantation, but the primary mechanism is inhibition of fertilization. You'll ask me that how is it possible? If you just look at the uterus over here, and let us say the intrauterine device is like this. The thread is hanging out. This is the thread. And this is the intrauterine device. So what is the action? What are the effects of the intrauterine device? The first effect this intrauterine device will have is on the cervical mucus. It will cause biochemical changes in the cervical mucus. These biochemical changes, because of more copper, they somehow inhibit the sperm motility. They will inhibit the sperm motility. So for example, if the sperm is here, this sperm is not able to cross the uterus and enter into the fallopian tube. That is inhibited. The sperm motility is inhibited. The second mode or the second effect that this intrauterine device can have within the uterus is that it can alter the cervical mucus in terms of thickening of cervical mucus. Why does it thicken? Because there is a foreign body and there are some alterations in the cervical mucus. There is thickening. If very simple, if the cervical mucus becomes more viscous, it becomes more thick. So the sperm motility is again blocked. The sperm cannot go inside the fallopian tube. So again, thickening of cervical mucus and biochemical changes to stop the sperm motility, they actually prevent the sperm from entering into the fallopian tube, and therefore there is no fertilization. So therefore we say that the primary mode of action of an intrauterine device is to block fertilization. Of course, if in case the fertilization is there, definitely there would be a foreign body reaction. Third mechanism is a foreign body reaction, and this foreign body reaction will actually prevent the implantation also. So there are three modes or three things which are happening in the uterus. There is foreign body reaction, there is cervical mucus thickening, and as well as along with the thickening, there is alteration in the biochemical environment of the cervical mucus, which causes all these things to prevent fertilization much more than preventing implantation. So what we have done till now, we have talked about the types of IUD, and we have discussed about the mechanism of action or mode of action of the intrauterine device. Let's take the third point, that what are the timings of intrauterine device insertion. What are the timings of intrauterine device insertion? If you look at the timings of intrauterine device insertion, we can talk in terms of after delivery, in case the female comes after delivery. So beta, please note that the female is same, the IUD is same, the doctor is same. It is only that when we insert the IUD, the name changes. So in case, first scenario, in case we are inserting within 10 minutes of normal vaginal delivery, in case we are inserting within MCQ within 10 minutes of a normal vaginal delivery, that is called as a post-placental IUCD insertion. That is called as a post-placental IUCD insertion. Second, if we are inserting after 10 minutes, but within 48 hours. So if you are inserting within 10 minutes, that is a post-placental. If after 10 minutes, but within 48 hours, that is called as a post-placental postpartum IUCD insertion. Okay, so within 2 days, but after 10 minutes, that is called as postpartum. Please note that IUCD should not be inserted. It is not recommended to be inserted in a delivery female, post-delivery female, after 48 hours. It is not inserted after 48 hours. So when do you insert in a female? Please note that we can insert IUCD. The female can get a IUCD inserted after, if the female gets IUCD insertion after 6 weeks. After 6 weeks, that is 42 days after delivery, 6 weeks of delivery, that is called as interval IUCD. That is called as interval IUCD. So basically, after delivery, you will have 3 times to study. One is a post-placental, postpartum, and interval IUCD. Next in line, what will happen in case about the cesarean section? Common sense, in cesarean section, you cannot insert IUD after the cesarean is over because you have already sutured up the uterus. The uterus is sutured up, the abdominal skin and the fascia, everything has been covered, right? So you cannot insert anything IUD after the operation is done. So only way or only type where you are going to insert the IUD during cesarean is during the cesarean. That is called as cesarean IUCD insertion. Please note that IUCD cannot be inserted in cesarean operations after the operation is done. Common sense because of the stitches, right? The fifth is in case of normal female. Now comes in case of normal female that the female is not pregnant. In normal female, please note that IUCD can be inserted anytime. Provided we are able to rule out pregnancy, then we can insert IUD in a female anytime. MCQ will not be so simple. MCQ will be which is the best time. The best time to insert IUD or the recommended time is to insert within first 10 days, 1 to 10 days of start of menses. So it is between the first 10 days of the start of menses. Why do you think that is the best time? Because common sense, the female is, you're pretty sure that the female is not pregnant during that time. And what is the ideal time? MCQs may still be sillier over here. What is an ideal time? Please note that the ideal time is within first 5 days. Of course, it is difficult to insert IUD during the bleeding phase, but within the first 5 days, it is taken as the ideal time. The best time is within first 10 days. During cesarean, it has to be during cesarean. So during cesarean, it has to be during the cesarean. Post-placental after 10 minutes. Postpartum after 10, post-placental was within 10 minutes. Postpartum is after 10 minutes, but within 48 hours of delivery. So an interval is you do the IUCD insertion after 6 weeks. Please note that after abortion, when are we going to insert? After abortion. After abortion, when the IUCD should best be inserted. In case the female has gone a surgical abortion, in case it is a surgical abortion, DNC, it should be inserted usually within the day 12 of abortion. And in case it is a medical termination, then the IUCD usually should be inserted on or around the day 15th. Why day 15th? Why? Because that is the second follow-up. So you should be rule out any infection or any retained products inside the uterus, and then after 2 weeks you can do IUCD insertion, medical termination of abortion. In surgical abortions, it is usually around or within the day 12 of abortion. Next is what are the IUD's side effects? Please note that the side effects of intrauterine device could be pain, it could be bleeding, it could be perforation, it could also be a pelvic inflammatory disease, or it could also be ectopic pregnancy. MCQs on this. Which of the following is the most common side effect? What do you want to answer? Which of the following is the most common side effect? Most common has to be most common. It is the bleeding. Most common side effect is bleeding. Please do not answer Mr. Pain. Pain is the most commonly answered wrong answer. Pain is a very important, it is the most common reason for removal of intrauterine device, whereas which of the following is the most common side effect? The most common side effect has to be bleeding or simple spotting. Simple spotting or very little bleeding is what is the most common side effect of intrauterine device. Of course, the dreaded complication could be perforation, it could even be pelvic inflammatory disease. Talking about this ectopic pregnancy, this is again a topic of interest from MCQ point of view, 3 by 5 star MCQ point. What do you mean by ectopic pregnancy? It means that the pregnancy happened anywhere apart from the uterus. Why on earth would anybody get a IUD done? IUD is inserted to prevent pregnancy. So at outset, we should discard this option that the pregnancy is obviously averted. There is no pregnancy, so leave aside the ectopic pregnancy. So why do I still write down that ectopic pregnancy under the side effect? Please note that IUDs, ectopic pregnancy is a side effect of IUD. True, false? Answer is false. Ectopic pregnancy is a side effect of third generation IUD. That is, answer is true. See, ectopic pregnancy is a very specific side effect of the third generation IUD. Why? So what is the role of progesterone? You must have learned it in your physiology lectures from KK sir that the role of progesterone in a female, the role of progesterone in the female would be to delay the tubal motility. So now if the third generation IUD is there and by chance there is unwanted pregnancy, then what will happen? The progesterone secretion is there and the unwanted pregnancy was there, like the fertilization was there in the fallopian tube and the fallopian tube has delayed motility. So technically there is higher chance of what? There is a higher chance of ectopic pregnancy, usually associated with which generation? With the third generation IUDs. So please note that ectopic pregnancy is a reserved side effect with the third generation IUDs. And I want to make it clear, ectopic pregnancy is not a contraindication for IUD insertion because in Government of India, we are giving copper T 380 and 375. So please note that ectopic pregnancy may be taken into consideration when we are talking about the third generation IUDs. But overall, if you see that ectopic is a side effect of IUD, third generation, yes. Ectopic is a contraindication of IUD, answer is no. I know it's written in your PARC textbook, but in the Government of India, the manual for contraception for medical officers, the training manual, it specifically says that previous ectopic pregnancies may not be considered as a contraindication for intrauterine device insertion. So now, based on the side effects that you have studied, let us go and see what are the contraindications of intrauterine device. The contraindications can broadly be classified into absolute contraindications or the relative contraindications. Absolute, very simple. I think the gynae people will be after me that we teach absolute contraindication at the suspected pregnancies, but that's how it is, that the first absolute contraindication is that the female may be pregnant. In other words about the pelvic inflammatory disease, please note that if the female is currently having a pelvic inflammatory disease, that automatically becomes a contraindication of intrauterine device insertion. Any vaginal bleed which is undiagnosed can be cancer. Again, that is a contraindication of intrauterine device. Again, cancer of the cervix, of the uterus, adnexus, or of the any female genital tract. Any cancer is a contraindication of IUD insertion. So please note that these are the absolute contraindications. This list does not include, I'll specifically mention over here, this list does not include ectopic pregnancy. I know that in PARC textbook, ectopic pregnancy is written as one of the contraindications for intrauterine device, but I've said it before also that the medical training manual for contraception for medical officers, explicitly it says that IUD, ectopic pregnancy is not an absolute contraindication for IUDs. You have to see on case-to-case basis. What are the relative contraindications? Definitely one of a big time relative contraindication is in case the female is having severe anemia, then it's not advisable, it's not recommended to insert IUD because IUD again may cause bleeding and anemia may precipitate more bleeding, so it could be a huge bleeding. Menorrhagia, history of pelvic inflammatory disease since last pregnancy. I told you that the current PID will be an absolute, but the history of PID, if the female is having PIDs again and again, recurrent PIDs, that would become a relative contraindication. Purulent cervical discharge, distortion in the abdomen, in the uterine cavity, any anatomical distortions, malformations, fibroids, that will all be relative contraindications. And of course, unmotivated person means a female is not in the capacity to check for the thread of the IUD. In those cases, IUD will be contraindicated. So please note, we have discussed about the 4 topics in intrauterine devices. We have discussed about the 4 topics in intrauterine devices. We have talked about the types. Very important. IUD is a 5 by 5 star MCQ topic. We have talked about the types. We have talked about the mechanism of action, side effects of IUD, and the contraindications of intrauterine devices. Every word has been important in intrauterine devices.